like weight and height, length. And both the weight and the height and the length had a significant increase. And there was also a significant decrease in the severity of the seizures and the frequency. And even though they were on a ketogenic diet, there was also no significant changes in the lipid profile of these patients, and their Vineland test showed significant improvement in their adaptive behaviors, about 65% of the patients. So we know that ketogenic diet is extremely famous in the nutrition scene, and how it can be perhaps used for losing weight as such, because it's a low carb diet, right? So I found this study pretty cool. And I thought that this was an extremely interesting aspect that we should be discussing on how diet can perhaps be used to treat and help patients cope with various different neurological diseases. In this case, was epilepsy. So this was a very, very cool study that I came across, and I'll be following it further for more updates in the future. Thank you.
Thank you so much, Muskan, for that wonderful article. I'm really glad we have you here to present us with such novel articles, something that we haven't heard of before. So thank you again for that. Now, it looks like it's time for our keynote presentation section. So I'd like to pass over the mic to our host, Madhuri.
Thank you so much, Ahmed, and welcome everyone to MedNews Week conference. I'll be passing our mic to Dr. Yan and Dr. Park to introduce our speaker for today.
Yes, great to be here. I'm very excited to have Dr. Gralow here from ASCO, a very special show here. I want to quickly introduce my co-founder of MedNews Week. Dr. Jan Leifman has been recognized one of the top international researchers by ASH and ASCO, founder and inaugural president of the ASCO Oncology Interest Group at his medical school, and also multi-time presenter at the ASCO Training Symposium, including at the previous year, and a member of the JCO Precision Oncology Peer Review Mentorship Fellowship. And his life and passions and overcoming Chernobyl as a survivor was featured at the Conquer Cancer Awards campaign at last year's ASCO meeting. So passing the mic to you, Dr. Yang.
Thank you so much, Dr. Park, for that great introduction. It's an honor to be here. And now, hello, everyone, and welcome to MedNews Week Conference, where we bring you the most cutting-edge medical information with leading physicians in the field. I'm Jan Leifman, one of your co-founders of MedNews Week Conference. Before I begin, I would like to first introduce my co-founder, Dr. Chandler Park. Dr. Park is the president of the Kentucky ASCO and has published in over 100 peer-reviewed publications, including in the prestigious New England Journal of Medicine 3 times, and the host of the National Lecture Series for General Oncologists called Masters Lecture Series, and also sits on the medical board of directors for Doximity as its oncology representative. We are fortunate to have a great team to make these events a reality. Our chairs include Dr. Park and myself. Our associate directors include Muskan Joshi, Gayatri Menon, and Madhuri Balab Suman, and Pratusha Ganta. Our managers include Alexandra Van de Kijft, William Wilkerson, and Pallavi Pai. Our educational committee is comprised of Shan Jakewitz, Shubha Pawar, Ahmed Hashim, Choria Harshal, Shervika Kanan, Carolina Faraz, Rita Khan, Sri Vallabheni, Isabel Miyawaki, Sumya Nadar, Helena Koloma, Rabab Hunab, Ahmad Zahid, and Victoria Maya. I would also want to thank our amazing partners. VMedi is a global leader in medical education content, and the National Society of High School Scholars, an honor society founded by Klaus Nobel of the Nobel Prize family. The moderator for today's event is Muskan Joshi. And now to introduce our amazing keynote speaker. It is my esteemed honor to welcome Dr. Julie Gralow, the Executive Vice President and Chief Medical Officer of ASCO. She's a Professor Emeritus of Medical Oncology at the University of Washington School of Medicine and the Adjunct Professor in the Department of Global Health at the University of Washington School of Medicine and the School of Public Health. Dr. Gralow is a global leader in global oncology and breast cancer. She's also an internationally acclaimed researcher in breast cancer, leading over 100 clinical trials in breast cancer that have led to enhanced outcomes for patients. In addition to her position at ASCO, she has held numerous leadership positions, including from SWOG, National Cancer Clinical Trials Network, as its former executive officer for breast and lung cancer, and the former vice chair of the Breast Cancer Committee. Her vast contributions to the field have been recognized with many awards, including the prestigious 2021 OncLive Giants of Cancer Care Award, an award that recognizes one oncologist globally for excellence in their respective specialty. Dr. Gralow is also a recipient of the ASCO Humanitarian Award and the Helen H. Jackson Women of Valor Award for Medicine and Healthcare for her many contributions to global oncology. Her interests lie in women's empowerment and education, as seen by her efforts in uplifting women of middle and lower income countries. She's the founder of the Women's Empowerment Cancer Advocacy Network, also known as We Can, to support cancer advocacy and education in lower and middle income countries. She's also an advocate in uplifting and providing support for female cancer survivors. And this belief led to her being a co-founder of Team Survivor Northwest, a nonprofit aimed at helping female cancer survivors improve their health through fitness and education. Dr. Glow's tremendous work in the field of breast oncology and the work she has put in for the empowerment of women's cancer survivors and the upliftment of women from lower and middle income countries is nothing short of amazing. And her profound impact has transformed her into an icon in the field of oncology. We at MedNews Week are honored to be hosting her today. And with this, it is my honor to welcome Dr. Julie Gralow. Thank you. The floor is yours.
Thank you, Jan. That was an amazing and somewhat embarrassing introduction, but I really appreciate it. I appreciate the opportunity to be here, but also to learn more about MedNews Week and all of your amazing people who are working with you. And I hope many of you, I understand some of you are quite early in your careers, will go into oncology, and I'll get to interact with you when you become oncologists as well. I'm going to share my screen and get started on my talk. So just give me a second to get my screen shared here. We had a little discussion about what I should talk about. And I'm going to focus on ASCO, the American Society of Clinical Oncology's global efforts to improve cancer care. It's going to be a bit of a whirlwind, but I understand this is recorded, and I'm happy to share the slides as well. So what is ASCO, the American Society of Clinical Oncology? Well, we are a professional organization of the people, the clinicians who care for patients with cancer. Our mission is conquering cancer through research, education, and promotion of the highest quality, equitable patient care. And our vision is a world where cancer is prevented or cured, and every survivor is healthy. It's good to have an ambitious vision. ASCO, even though we have that A, American, in our name, is truly a global organization. At our annual meeting, we have last year 40% international attendance. In the pre-COVID era, it was about 50% of our attendees came from outside of the US. Our membership is 1/3 international. And those international members represent 150 countries, those that are filled in teal here on this map. And we have more than 45,000 members. Our current 5-year strategic plan is under re-review starting next year, but the current one has a goal of make a global impact. So for the past 5 years, this has been something that we've been working with our staff, with our board, and with our members on trying to achieve. And our 5-year outcome is that ASCO leads the delivery of information and diverse expertise that's needed by the global oncology community to reduce the burden of cancer. Our global engagement spans our 3 mission pillars. Mission pillar number 1 is research. We have international research courses and international innovation grants, young investigator awards in global oncology, long-term fellowship awards, and we've created a journal, JCO Global Oncology, specifically to publish research in global health. Our second mission pillar is education. I'm going to tell you a little bit about our International Development and Education Award, our IDEA Award. We have virtual mentoring. We have international courses. We partner with a group called Project ECHO to deliver virtually a variety of education courses. We've recently created in the last few years a meeting called Breakthrough that occurs in Asia. I'll tell you a little more about that. We have different Best of ASCO meetings around the globe. A few years back, we added a global health track to the education track of our annual meeting to make sure we were talking about global health and cancer at the meeting, and we have global webinars. And then our third mission pillar is quality, meaning a focus on quality care. We have programs called our Quality Oncology Practice Initiative, that are domestic and international, and quality training programs. We create resource stratified guidelines that are adapted for use in lower resource settings. We have an international cancer corps where we partner strongly with individual cancer centers in low and middle resource settings. And we partner with a group called CCAN, or City Cancer Challenge, which I'll tell you a little bit more about. Here's what I'm going to focus on. We have a lot of work globally, as you've just seen, but our major areas of focus in our efforts to improve cancer care globally are leadership development and education, access to essential cancer medicines, quality cancer care, and cancer research. In order to better hear from our members to understand how ASCO can help those in other parts of the world, we began in 2019 to engage a series of regional councils. So we started with Asia Pacific in 2019. We then launched a Latin America Regional Council in 2021. Our most recent regional council is in Sub-Saharan Africa, which we launched late last year. We were all ready to launch a Central and Eastern European Regional Council and had already selected representatives for that just before the war in Ukraine broke out. So that is currently on hold, and we're hoping for peace soon so we can resume that. Our regional councils were convened to increase our engagement with our international members. So we ask them to advise us on their needs and challenges in their region. We ask them to look at the ASCO programs and services that we already have available and see how they could be adapted that might address regional challenges. We ask them to identify opportunities and learnings that we don't have already that could be applied in their region. They serve as a forum to network, collaborate, and develop local solutions together. And they help us raise awareness and increase engagement in their countries in ASCO opportunities. Because it's been around the longest, I have one slide just showing you an example of what the regional councils have done. So this is the Asia Pacific Regional Council, launched in May of 2019. One of the first things they did was we had a competition, if you will, for a new international cancer corps site, and Sarawak General Hospital in Borneo, Malaysia was selected. And some of the things we've been working on with them, because of course the pandemic promptly hit, were some virtual training courses. They picked palliative care as a high priority, and we're now working with them on a quality care improvement program. They told us that they liked our ASCO leadership development program, and they wanted their own version adapted to the Asia Pacific region. And we've actually already graduated our first class of our Asia Pacific Leadership Development Program with 12 participants in the first round. And we're just gearing up for our second round in our second year. Because COVID happened soon after this regional council was launched, they asked us for a webinar series, trying to help learn from each other about how to deal with the pandemic. We held our first ASCO breakthrough meeting, which is a meeting aimed to be held, not a replication of our ASCO annual meeting, but one tailored for the region in Asia Pacific. And the first one was held in 2019 in Bangkok, and we're gearing up for a 2023 meeting in Yokohama, Japan in August of this year. We also are in the process of preparing a JCO Global Oncology special series on research in Asia in partnership with this regional council. Another way that we are asking our international members, how can we help you? What are your problems? Is we did this survey in 2021 of 20 different countries. And one of the questions I'm showing here, how can ASCO add value to you, your patients, and cancer care in your country? And the top 3 responses, they varied a little bit, but they were access to essential drugs, cancer registries, and pathologic diagnosis. Now, we, as an organization that mostly represents medical oncology, felt we could do the most good here in looking at access to essential drugs and then partnering with other groups who work on cancer registries and pathology. So we launched an access to essential drug investigation and interviewed 20 plus different organizations that are working in this area of improving availability and accessibility of cancer medicines. And it became clear very quickly that although cancer medicines are very expensive, and that's one of the problems, it's more than just cost. If we are going to get widespread availability and access to cancer medicines globally, we first need to define high priority cancer drugs. We are not going to get every single cancer drug available everywhere. And so we are working off of the World Health Organization's essential medicines list, where they have a team that evaluates the efficacy and the toxicity of drugs, takes into account cost, and then places them on an essential medicines list, telling governments that these are very important drugs that you should strive to have available. There is the cost, the affordability, and it's not just to the payer, whether it's the country or a private insurer. A lot of the cost is borne by the patient. Accessibility means it has to be included in budgets and national cancer control plans and insurance coverage. And to be able to get access, you have to be able to procure the drugs and to transport the drugs. We have to assure that the drugs that we're getting are quality. So we need to register within countries and have regulatory oversight, make sure that the drugs that we're buying and bringing into a country are what they say they are and are of high quality. We need a healthcare workforce that can deliver the cancer drugs. It's not just about getting the drugs. We need a healthcare workforce that understands how to use them, that can safely give chemo. We need a health systems infrastructure, and we need chemo safety. And then we have to make sure that we're monitoring and using these drugs wisely. So we need guidelines and pathways. We need to have biomarkers for most of the newer cancer drugs. You need to know if a tumor expresses a certain feature, and we need to monitor and evaluate how we're doing. Are we using these drugs wisely where they have the most benefit? So after doing all of this research, we hosted an ASCO Access to Essential Medicine Stakeholder Summit in June last year at the annual meeting. We then worked on some high priority projects, formed some working groups. We had another meeting in Geneva at the UICC World Cancer Congress in October, and we're planning a follow-up in June of 2023 at the annual meeting to see where we are, what have we done, have we gotten anywhere? In all of our investigations, we felt that ASCO could make some of the best contributions by partnering. We can't do this alone. ASCO is not going to be able to go out and get all these meds. And so we are proud to be a partner with the Union for International Cancer Control's Access to Oncology Medicines Project, or ATOM. The ATOM Coalition was launched in May of last year, and it has more than 30 public and private sector partners. The goal is to increase access and availability of cancer medicines in low and lower middle income countries. And the strategy is to bring partners together with expertise and track records in all of the different things that are needed that I showed you on the prior slide. So our expertise that we're adding to the ATOM Coalition is in education, capacity building, and quality care. The way that the ATOM Coalition is proceeding is that we're going to start with 5 to 10 countries and then grow to 40 plus. We're very close to announcing those first 5 to 10. Then we'll make available WHO essential medicine list medicines. Some will be generic, some will be biosimilar. And then through some innovative methods, we're going to try to get some of the newer targeted agents. We're going to initially focus on breast cancer. We'll plan to add prostate, cervical, lung, colorectal, and pediatric. And with the medicines patent pool, and by working with industry, we have some examples where we're securing voluntary licenses of drugs that are still on patent so that we can get access to some of these newer on-patent drugs. And we can use any proceeds that are made through this volunteer licensing to feed back into the program again. Now, moving on to leadership development, our International Development and Education Award, our IDEA Award, is now 20 years old. It started in 2002, and we've now had 400 plus IDEA recipients from over 70 countries, those that are in blue here on this map. The picture on the right is some of our IDEA recipients, alumni, and mentors, and our steering group members at the ASCO annual meeting this past year. What the IDEA program does is you need to be junior in your career, and if you are selected, it's fairly competitive, then we will pay for you to come to the annual meeting. We will partner you with a mentor, generally in the United States or Canada. And after the annual meeting, we will pay for you to go with your mentor back to the mentor's home institution and spend some time, up to about a week, just to start off a relationship. We are using these IDEA recipients who are generally the up-and-coming leaders in their country as a pool for ASCO volunteers that we want to put on committees and offer opportunities to, so that they truly can become leaders back in their own countries. Prior to joining ASCO, I was a primary mentor for 3 different IDEA recipients, and I can tell you that they all have evolved into true leaders, one of whom is our Romanian representative on our hopefully soon to be launched Eastern and Central Europe Regional Council, and the other is leading our Latin America Regional Council. I mentioned earlier something called City Cancer Challengers, CCAN. This is a unique initiative that was initially launched by the Union for International Cancer Control, where instead of focusing at an institution level or at a country level, we get commitment at a city level on wanting to really change across a whole city in a low or a lower middle income country, the cancer care, prevention, screening, etc. And so we partner with City Cancer Challenge by providing, again, education and access to our resources. There are now 13 cities that are part of CCAN, and you can see them on this map. Some were just announced in the last few months. And a very interesting thing that we launched this October was a leadership program for women in oncology. And we picked one young up-and-coming woman leader in oncology from each of the cities. And we brought them to Geneva for the World Cancer Congress, where they all got to interact and to meet each other and to begin a year-long program in leadership for women globally. And they are just amazing. I got to have a session and a dinner with them, and then meet up with the one from Porto Alegre, Brazil again. This is really a fun program, and hopefully every year we'll be able to repeat it, although we haven't committed to the money for that yet. So within Conquer Cancer, which is our amazing ASCO Foundation that fundraises for us, In addition to the IDEA Award, I've already mentioned we have a Global Oncology Young Investigator Award, an International Innovation Grant, a long-term international fellowship, and an International Women Who Conquer Cancer Mentorship Award. This picture is of the stage at 2022 of all of the Conquer Cancer Award recipients. And remember, 2022, we still had a lot of people participating virtually. So this isn't even all of the recipients. I'm afraid we're going to break the stage this next year because Conquer Cancer just keeps going out and getting more money to fund more awards. But you can see, even just looking at the front row here, that this is a very international mix. We created JCO Global Oncology as a publication that would be able to publish research on the challenges that healthcare professionals and resource-constrained settings face in conducting research and caring for patients with cancer. And Gilberto Lopez is the editor of JCO Global Oncology. There are opportunities. I think I heard that Jan is doing an editorial opportunity in one of our JCO journals, and there are opportunities to be a junior editor and do some training with JCO Global Oncology as well, if you're interested. And again, in supporting global oncology research, we signed in June a memorandum of understanding with AORTIC, the African Organization on Research and Training in Cancer. And the primary collaboration is going to be on cancer research and clinical trials. And so this is us signing the memorandum of understanding. And here's a paper from a workshop that we did on action for increasing diversity, market access, and capacity in oncology registration trials. Is Africa the answer? So we're looking forward to working with our aortic colleagues in partnering to bring clinical trials to Africa, which will benefit us all. In quality care, we have very important, well-respected quality training program, which is either 6 months or 1 day. And a whole team of oncologists come together and they work with each other to lead quality improvement activities in their own practice. We've had 270 international participants in this in 9 countries with the flags represented here. These are just examples when you apply either to the 1 day or the 6-month program. These are examples of some projects that have been done. There was one team that wanted to decrease the time to antibiotic administration when febrile neutropenia occurred. Another that wanted to work as a team to decrease the appointment wait time. Another to decrease nursing burnout. Another to increase the screening at their facility for emotional distress. And then another to decrease the time until they could get access and dispense oral chemo once the prescription was written. We have our Quality Oncology Practice Initiative, or COPI, and to date we have 709 physicians and 21 practices internationally involved with COPI and hundreds more in the US. And then we have a COPI certification, which is the next step, and you prove that you are meeting high quality care in various different COPI metrics. And this is a 3-year certification that recognizes very high quality care. And we have 27 international practices that are actively certified. Now, COPI, the Quality Oncology Practice Initiative, is hard to meet all of those standards in a low income country. So we have a pilot COPI LMIC project, which introduces practices to quality measurement and reporting, to identifying gaps, and then start on the pathway toward quality improvement. And so we're piloting our ASCO International Cancer Course sites, this LMIC COPI project in Honduras, Uganda, just ramping up in Malaysia, and just selected the site in Bolivia. This is a picture of Dr. Jackson Oram, the director of the Uganda Cancer Institute. He has just been a true leader in supporting quality care and this initiative. He said, we need to prove to ourselves so we can prove to our patients that we are delivering quality care. And they picked just 5 core measures from our standard COPI measure set. They picked measure one was just, does the medical record have a path report that confirms malignancy that everybody can see and have access to? Measure two was, is staging documented within 1 month of the first office visit for the cancer? Measure nine was, is there a documented plan for what chemotherapy is recommended, including doses, the route, and the time intervals? And then measure 12 was, is there documentation of what was actually received? And then the measure three was pain assessed by the second office visit? Dr. Oram gives a very amazing talk about, he thought these are obvious things, we should be doing them. And when they went and looked at what they could prove through the medical record in a way that was visible to all that they were doing, they found that they really were not meeting any of these. But then they quickly worked on, once they've identified the gaps, on a path toward quality improvement. And they have markedly increased this and are ready to take on more. Now, where we're going in the US with our quality oncology practice initiative is we're piloting something, the next step, and it's called the ASCO Patient-Centered Cancer Care Certification, APC4. And this is more involved. It involves 17 oncology medical home standards. I've given you a reference for that here. These were developed by ASCO in partnership with COA, the Community Oncology Alliance, and then there's 22 chemo safety standards. So the 7 major pillars of this oncology medical home are centered on the patient, patient-centered care, and they start with patient engagement. What's the access and availability of care? Is the site practicing evidence-based medicine? Is the care equitable and team-based? Do they have quality improvement monitoring and measures in place? How about goals of care, palliative and end-of-life discussions? Are these a central part of the cancer care? And then chemotherapy safety. So we piloted this now in 12 US practices across 88 sites and 500 physicians, along with 2 payers. And we're working on moving this to the next phase. Now we're working on adapting this to an international pilot. We're doing an international readiness survey, and we're working on, do they agree with these standards that we've selected, and how are we going to measure pathway compliance? It would be nice if we could get it easily out of the electronic medical record, but sometimes it has to be hand done. Some countries don't have an EMR. What are we going to do about cost of care and evaluating that as a metric? How are we going to collect the data? And what's the incentive for a practice to do this? In the US, by having 2 payers on board, we're looking at, is there a benefit to the practice, to the payers, who would then incentivize the practices to be delivering this care? And is there a benefit back again to the patient? Because really that's what this is all about, is having the best care for the patient. Now we also have, under global quality care, just signed a memorandum of understanding with the World Health Organization. And again, we did this at the annual meeting where our presidential symposium speaker was Dr. Andre Ilbawi, a surgical oncologist who now leads the World Health Organization's cancer efforts. So our MOU has a goal of measuring and improving the quality of cancer care internationally. We're going to have 2 initial projects that will support WHO member states, which we're still working on selecting, and cancer centers by improving access to quality care. We're going to link facility level quality improvement activities with national strategies. So we need the country to buy in, to want to be part of this project, as well as the specific cancer centers that agree to participate in this project. And when we talked about what do we want our priorities to be in these quality improvement projects, we took a look and talked to the WHO about what their priorities are. And you may have seen that just last Friday, the WHO launched a new global breast cancer initiative led by Dr. Ben Anderson. And the 3 pillars of this breast cancer initiative revolve around detecting cancer early, with the goal of 60% of cancer being diagnosed at stage 1 or 2, diagnosing on time, having a 60-day or less interval between presentation of signs or symptoms and diagnosis, and then treating better. Pillar 3 says at least 80% of your patients will complete all of the intended course of care. Now, in addition to breast cancer now, childhood cancer, cervical cancer have been WHO priorities, and they have initiatives in those. And palliative care is linked into all three and is another high priority. So when we selected what we wanted to do as we start off our WHO ASCO collaboration is we're going to measure breast cancer management, and we now have this new global breast cancer initiative that WHO has launched to work off of, and we're going to impact palliative care quality. So we're going to have them report and monitor. We're going to establish a learning collaborative, so all of the countries learn from each other who are involved in this. We're going to help them with quality improvement training and quality monitoring. And then, of course, we're going to report and publish the project outcomes so we can all learn from it and help each other. Also in quality, in addition to our evidence-based clinical practice guidelines that ASCO routinely develops and publishes, we now have a working group on resource stratified guidelines that are adapted to the resource level of a region. And they're guidelines. They are not telling a country what they should do, but they're talking about at a low, an intermediate, and a high level of resources, what would be reasonable within a given disease type and stage. So we now have published cervical cancer guidelines, palliative care guidelines that are resource stratified, colorectal and ovarian, and soon we will be publishing a metastatic breast cancer resource stratified guideline. Another thing that we've done globally is to support our colleagues in Ukraine. And I told you that we had already picked our representatives for the Eastern Central Europe Regional Council that we were planning to launch. So Andrei Hrinkiv, seen here from Ukraine, was our pick for our ASCO Regional Council representative in Ukraine. He's a cancer surgeon in Lviv in Western Ukraine. So with colleagues from our regional council throughout the European Cancer Organization, we quickly formed a ECHO ASCO Ukraine Crisis Special Network on the impact of the war in Ukraine on cancer, and then bringing our Ukrainian colleagues in, seeing what we could do to help, as well as having representatives from the neighboring countries who are on the receiving end of some of those who left Ukraine, including the cancer patients. So we are working hard on this. Just had another call this morning on this and working on, okay, what are we going to have in place where we're ready to go as soon as peace occurs and we can go back in and help them rebuild. It's going to take years to rebuild what they had, even if this all ends tomorrow. So we are here to support. And look at everybody, all of the different societies and cancer centers, et cetera, who have joined on to this special network in trying to help our colleagues and their patients in Ukraine. And I'll end with, this is less than ASCO, more a Julie Gralow passion, but we absolutely respect and include patients as partners in everything we do at ASCO. But this is my weekend network that I developed actually from early work that I did in Ukraine back in the late 1990s with USAID and Ukraine Ministry of Health project called the Ukraine Breast Cancer Assistance Project that was led by a group in Seattle called PATH, and I was a medical oncology consultant. Now, you know, the UN tells us we should be working with patients. In a 2017 World Health Assembly cancer resolution that comes out of the UN, one of the bullet points was we should continue fostering partnerships between government and civil society, building on the contribution of health-related non-governmental organizations and patient organizations. So they're telling us this is one of the ways that we need to work together to improve cancer outcomes. And this shows some recent pre-pandemic pictures of WeCan, Women's Empowerment Cancer Advocacy Network conferences. On the top is one in Kampala, Uganda. We have an East Africa WeCan group where about 10 to 12 countries, breast and cervical cancer patient advocates come, and we provide an infrastructure for them to network, to tell each other about their successes and some of their barriers, and to support each other. And then below is what came out of my Ukraine work in the late 1990s. WeCan had its first meeting in Eastern Europe and Central Asia back in the early 2000s in Kyiv. And so this is a more recent picture back in 2017, which was the last time I was in Kyiv. And again, we have 10 to 12, mostly former Soviet countries, the breast and cervical cancer patient advocates here, to try to work together, work with their physician and healthcare colleagues, work with their governments to get the best outcomes for those who are impacted by cancer. So WeCan works by empowering, connecting, and educating cancer patients to improve cancer outcomes globally. I'm really crossing my fingers, and I'm going to state this out loud where lots of you are listening. We think our Malawi WeCan conference that had been planned for March of 2020 that has been postponed now because of the pandemic, we think we're going to be able to hold it in May of this year. So we're working hard on that, and we'll do it if it's safe to bring everyone together. So my second to last slide here, how we've heard about a lot of projects you might want to know about more. You can join the ASCO My Connection Global Network. If you're an ASCO member, it's a community where you can talk to each other, ask each other questions, share your experiences by writing articles or blog posts for our ASCO Connection publication. We can engage on social media. MedNews podcast is very good on social media, but we can also, ASCO isn't quite as prolific, but we are on Twitter, Facebook, LinkedIn, and Instagram. Haven't made it to TikTok yet. I saw this advertised on TikTok today in my talk, which I was very impressed with. And then you can also become an ASCO member. If you're a student, a trainee, or a fellow, it's free. If you're a professional in a low or middle income country as defined by the World Bank, it's free. And then there are discounted rates for upper middle income countries, and you can join at join.asco.org. So in conclusion, 2 days ago, Saturday, was World Cancer Day, February 4th. The theme of this year's World Cancer Day was Close the Care Gap. That is what we're working on. We cannot do it alone. ASCO is a partner, a collaborator with many organizations, as I hope you've seen in this talk. And when you made your poster, when you went on the World Cancer Day site, you could pick some pre-made sayings, and I liked this one: strong alone, but unstoppable together. Working together, we can improve cancer care in every part of the world. Thank you very much.
Thank you so much, Dr. Gralow. That was outstanding. I just want to thank you for joining us today, and thank you for what you do for the society, and the impact that you have around the world is truly breathtaking. So, Dr. Leifman, I'll just kind of pass it on to you because I know we have a lot of questions from the audience.
Thank you so much, Dr. Park. Dr. Gralow, thank you for that outstanding presentation and the profound work that both you and ASCO are doing. ASCO is blessed to have you as its pioneer and leader, spearheading all of these initiatives. Given your mission to promote global equity in the sphere of oncology globally, what have you been most struck with over the past few years? And what sort of direct impact do you envision ASCO having on the global oncology stage over the next 5 to 10 years, if you had a crystal ball? Thank you.
Well, let me think just a second. I mean, when I came into this role 2 years ago, I was told, what do you want your legacy to be? Think about a big project where, you've got, the resources of ASCO and the staff and the amazing staff and everyone. What is it? And I talked with my Vice President of International Affairs, Doug Pyle. We mulled it over and came up with access to care, because I am a big researcher. I did clinical trials forever, but the more you travel the world, the more you realize that if we could just translate what we know now and have available now in terms of care, and what not everyone in the US has access to, but most of us in the US have access to, if we could translate that to the rest of the world, we would save tens, if not hundreds of thousands of lives tomorrow. And so that getting access to care with what we already know, I think, is something that I came to realize that while absolutely even people who have the best access to care and get everything are sadly still dying of cancer. So we need to do more research, but we could make a huge, amazing impact if we could get access to care. So that's why we're working so hard, not just on the access to cancer medicines, but partnering with the pathology and the surgery and the radiation and everything else that goes along with it. So I think that realization of that it's not just all about research, it's the translation, the implementation piece is something that I came to realize when I came to ASCO, and that I'm most passionate about.
Thank you so much. We truly are blessed to have you as the leader spearheading these initiatives, and we can't wait to see what amazing progress happens under your great leadership over the next 5 to 10 years. So now I want to pass on the mic to Muskan, who will direct the remainder of the question and answer portion. Muskan?
Hello, and thank you for coming to discussions with global leaders. I am Muskan Joshi, and we are excited to be speaking with Dr. Julie Gralow, who is the Executive Vice President and the Chief Medical Officer at ASCO. So excited to have you here with us. We have received a great deal of questions, and we'll do our best to get through all of them in time, and then we have with you. So for the very first question, I'm going to be passing the mic back to Gayatri.
Thank you so much, Dr. Gralow, for that very enlightening talk. So my question is, could you maybe shed a little light on the vast underrepresentation of women leaders seen in oncological trials, unfortunately, that still exist to this day?
So specifically, you're asking about leading clinical trials?
Right.
Yeah. We clearly have issues with gender equity. This is why within CCAN City Cancer Challenge, we chose to have a women's leadership development program and focus on that. I think, I have a lot of role models who were women and strong researchers and strong clinical trialists. I think it's important to see other women in these roles, to know that you can do it. We talk a lot about, the difference between mentorship and sponsorship and allyship. And while all of my direct mentors in my training, who I reported to, did work with, they were all men, I had a lot of sponsors who were powerful, amazing women that I looked up to. And so I think it is a problem. We have gender inequity. It's worse in some parts of the world and in some fields than others. In breast cancer, we have a lot of women in the United States anyway, which is terrific. but we need to support each other, and we need, we need to challenge the status quo, to make room for childbirth and to have kids and pregnancy, and that this is a normal part, of an academic career, and you're not burdened by it. I mean, that's just one example of things where women have been challenged, and maybe they stepped out of it, even though they were thinking they were going to go along a certain pathway. So we're working hard on those things in trying to kind of shake up a traditional promotion pathway and allowing for more flexibility in how we work. At my own institution, we had clinic was 8 to 12 and 1 to 5. And yet I had a lot of female faculty who needed to drop the kids off and couldn't get in until 8:45. And so working with the administration to be flexible about allowing that, that's critical, that's important. And of course they should prioritize their kids, over their clinic. So, I mean, there are just so many pieces, and I'm only touching on a little bit of it, which is the family and the childbearing, but we need to support each other, and we need to look at what kind of the institution and the status quo should be blown up.
Thank you so much, Doctor. I completely agree with you. That's definitely an issue that must be looked at these days. Back to you, Ms. Khan.
Thank you so much, Dr. Gralow, for that wonderful, wonderful answer. And I just want to say that we are incredibly lucky to be led by female leaders like you, who are paving the path for us, future women in medicine. So thank you for that wonderful answer. So for the next question, I'll be passing the mic back to Madhuri.
Thank you so much, Doctor, for this wonderful presentation. I truly learned a lot because I'm very interested in oncological care, and it's a specialty I want to go into. And I truly learned on how we can further impact this field as well. So my question is, cancer, when one develops cancer, there's a very profound economic impact on a patient who might not have insurance, or in societies where the patient is far younger and have to work for a living to earn money. So how can we help and address this situation as well?
Wow. Absolutely. A cancer diagnosis wreaks all havoc with your life, and it bankrupts so many patients and families as well. And we need to do much better in the US and globally. It wasn't until a handful of years ago that I started hearing this phrase, financial toxicity, which related to the whole impact monetarily back on the patient and the family. And it goes way beyond, as you've already pointed out, just money that's spent on cancer care. It's money that's coming in, by not being able to work, for example. It's being increasingly looked at. Our ASCO quality meeting we had this past fall had a whole session really on financial toxicity. The other thing that another term I heard just this past year for the first time is time toxicity as well. All of the time of your life that is required to go through cancer care or cancer clinical trials or whatever. And that these are things that when we look at kind of the classic, here are the chemotherapy side effects, you lose your hair and you have nausea and vomiting and all. Nobody ever really calculated out the additional impact on the patient related to the financial toxicity and the time toxicity. And that is increasingly being recognized. And by being recognized and having studies on it, the next step is, how do we improve it, right? So it's the recognition is the first step, and then how do we work on improving it? I think, we learned from the pandemic about how to make care more patient-centric, and it could be remote, and we could do telemedicine, and we could keep it closer to home. And we're working on that for clinical trials as well. A lot of people can't enroll in a trial because the site is too far away to be practical, to get there. But they have a nice cancer center nearby that is capable of doing most of the parts of the trial. So better partnership, decentralizing trials and making them more patient-centric. is going to help somewhat. I mean, the cost of the drug, we have a lot of talk in the WHO and is focused on getting universal health insurance broadly, but universal health insurance doesn't mean everything's covered. And a lot of countries that have universal health insurance do not cover cancer care. So it sounds good to say we have universal health insurance, but just like, regular insurance that we know of in the United States, it doesn't mean everything's covered. So understanding what the insurance package is in a given country is really key as well. So we recognize it. We're working toward what are some steps that we can improve it, but we can't be bankrupting patients and families. It's not okay.
Definitely, doctor. And I agree with your point that with how we're seeing a lot of recognition. And I hope in the soon coming years, we can see a lot of implementation and better policies bringing up as well. Back to you, Muskan.
Completely agree with you, Dr. Gralow, on that. Cancer is a financial burden, but it doesn't have to be. And as Madhuri just stated, I really hope that we can further implement better policies to make sure that patients have good care and no financial burden. So for the next question, I'll be passing on the mic to Ahmed.
Thank you, Muskan. Doctor, my question is, given the present innovation within oncology in terms of precision and targeted diagnostics and therapeutics, how do you envision this being translated to countries with less resources?
Well, great question. I just spent the weekend in Miami. One of the conferences I was at was a precision medicine conference, and another was a lung conference. And I could not believe, I'm out of training now in hematology oncology for 30 years, what just lung cancer, all of the different testing and genomics and all that needs to be done to decide, which drugs to pick. So I told you about that Access to Oncology Medicines Coalition. The actual executive director of it is the former chief medical officer for the American Society of Clinical Pathology. So you can bet that the pathology piece, the genomics and the germline genetic testing and the, all of that is being included as part of this access to medicines, because we know we can't adequately define cancers anymore, much less treat them without having all of that. We're looking for some innovative solutions. And, so I spent 30 years as a breast cancer expert just doing immunohistochemistry for estrogen and progesterone receptor and HER2. That, which seems so simple and shouldn't cost a lot, for some countries, they don't have the expertise and the manpower and the training, and the reagents even are too costly. So doing something that we think in the United States, stain for a few proteins, can be cost prohibitive. So a very interesting example that has been written up in a couple of different African countries is they have these machines that look at mRNA that they use for HIV and for drug-resistant TB. So it's like kind of just a machine that's easy to use. You put samples in and it runs it and it can analyze it. So they've modified these machines to do breast cancer, estrogen receptor, progesterone receptor, HER2. You just put a sample of tumor in and you can either use a fine needle aspirate or mush up a core biopsy, and it can do this for you, but at the RNA level, not at the protein expression level. And so this is something, these machines are everywhere throughout Africa, and people know how to use them. And so if you get a little cartridge and you can do this, you not only, it might cost the same amount of money as a reagent to do the estrogen receptor testing, for example, but the manpower piece and the equipment piece of not needing to slice it into little tiny, pathology samples. So that's an innovation that's going to just make it practical. They're using something they already know how to do for infectious disease purposes. And you don't need specialized manpower on getting these very thin slices of tumor, laid out on a slide and then staining them. We're looking at, for genomics, we're looking also at some more innovative techniques. It's getting cheaper and cheaper and cheaper and cheaper. It is, the more we know how to do it. And so there are some pilots that I'm hearing about moving some next generation sequencing into low resource settings. And then, of course, it's only worth it, in my mind, if you compare it to drugs that you would be able to then treat based on doing the next gen sequencing. So it's going to be innovation. It's going to be shaking it up. It's going to be, we don't need to do the same old. We don't need to just take the status quo and train low income countries how to do it. We need to blow it up and say, here's a really easy way. I mean, I like the example of cell phones in Africa. They never laid down landlines for telephones throughout Africa. They don't have what we had. Maybe some of you are too young to even remember that. But before we had cell phones, everything was landline and you had all these telephone wires and lines. They never had that infrastructure in Africa. But when cell phone technology came out and it was cellular, they quickly adapted it. And so they never went through the phase where they laid down all those landlines and they just jumped to the next step. And that's what we need, more of that. And we have lots of bright people in low and middle resource settings who are working on that. And we've got to give them the resources and the support so that they can experiment with this and just not necessarily just repeat what we're doing in high income countries.
Thank you again for that wonderful, wonderful answer. And I am so here for and so excited for the future and all the innovation that is yet to come in oncology. So thank you so much for that wonderful answer again. So for the next question, I'll be passing on the mic to Sean.
Thank you so much. So this couldn't have come at a more perfect timing. I'm a third-year medical student. I'm about to start my hem-onc rotation next week. Very passionate about oncology and very happy to have you here with us. So my question is, with the launch of ARPA-H by the Biden administration and its aggressive funding style, how do you and ASCO foresee this impacting the speed of cancer research and the translation into clinical oncology? Cancer oncology and its clinical implementation, it has sped up very fast, and while it still remains quite expensive, with more and more funding coming to this and more breakthrough sort of funding structures, it seems like things are just going to get even faster and maybe more miraculous. What are your thoughts about this?
I agree. It's an exciting time. I think we'll hear the State of the Union address tomorrow, where I think our president will play up again more about the moonshot and the funding, both at the conventional NCI level, but also through this ARPA-H. I think we've got to partner with all these amazing minds that are outside of oncology to figure out how to bring all this technology, artificial intelligence, machine learning. How are we going to get all of this in? It's here, but we, the oncology community, we don't know much about it, but we could, that's what ARPA-H is all about, just giving big chunks of money to be, really revolutionary and to bring partners together who don't normally get together. So, I mean, I did one of the two talks I did in Miami this weekend was at a lung cancer conference, but they asked me to speak on ASCO's perspective on the future of oncology care. So I did the talk. I was ending with AI and machine learning. And I went into ChatGPT and I said, ChatGPT, what should I tell oncologists about the future of oncology care? And it basically outlined the talk that I had just made. And, it hit all the bullet points and it was just perfect. So I ended my talk with that. And I said, it is not the future, it is here. And we need to not be afraid of it. We need to know the limitations, but we need to embrace it because this is going to take us to the next step. So I got a little off topic about the ARPA-H, but we still need, we can't just be doing this a little bit different, a little bit more, a little bit different. We do need people who are really looking at things that have the possibility of being a big breakthrough, as opposed to just a small incremental step. And that's what the promise, I think, of ARPA-H is. It's thrilling to have Dr. Monica Bertagnoli as the new head of our National Cancer Institute, a woman leader. We talked about women in leadership roles, and she led a clinical trials group, the Alliance for the NCI, and she has been very involved in something called Minimal Common Oncology Data Elements, which basically is a group, and ASCO is a part of it too, that's working on defining how the terms for everything, minimum common oncology data elements, to put in our EMRs. So we can pull things back out, information, real world evidence back out of what's going on in our EMRs. And the problem is we have, 100 different EMRs in this country, probably a lot more than that, and they're not talking to each other. So we're trying to build a language where the research can also come out of the real world, and we better understand who's being prescribed what and who's responding. So lots of promise there. And we need young minds who understand a lot of this stuff to help us. So I hope you love your hem-onc rotation, and I hope you go into oncology, and I hope you bring a really fresh perspective where you challenge the status quo.
Thank you so much again for that amazing answer. And truly, the future of oncology is something I am so looking forward to. So for our last question for today, we have Billy.
Hi. I just wanted to say thank you so much for doing this event, Dr. Gralow. As an undergraduate, getting the opportunity to learn from you about the training programs and current efforts in oncology has been really, really inspiring. So on a related note, our final question is, for our more junior attendees just getting into research and medicine, what inspired you to pursue the field of oncology? And how has this choice impacted your life? Has it been everything that you had initially anticipated? Thank you so much.
Thank you for that question. I knew I wanted to go to med school. I wasn't 100% sure at the end of high school, but I was pretty sure. And then in college, I did all the pre-med things. So, I always knew I wanted to go into medicine. And then I took a couple of years off in between undergraduate and med school for some personal reasons. And I wanted to get some experience in medicine generally. So I looked for jobs and got a job. It just happened to be an oncology research lab where they were making monoclonal antibodies to B-cell lymphomas. And actually, some of them went into humans way back when, decades ago now. And I loved the head of the lab, one of my early mentors. I loved all of the oncology fellows that I was working with. And what really made me decide then and there that I wanted to go into oncology was that you could combine the research with the patient care and see that the research you were doing was actually impacting patients, that we had a long way to go. So that there was a lot of opportunity to improve. And so I applied to med school, and I pissed off all my classmates because I knew what I wanted to do from day one, and none of them knew what they wanted to do, and they were stressing out about it. But it was, I just knew that this you could take care of patients and you could do research and you could have impact. And I just thought, what a better career goal. And you asked me, did I ever regret it? No, not one bit. It was one awakening was when I was finishing fellowship and starting to specialize in just breast cancer. One of the things was the patients were telling me, treatment's done now, and you're telling me go off and live a good life, and I feel like you're just leaving me in the lurch here. I don't know what to do, and I'm afraid of the cancer coming back, and I want to do everything I can, and I need help. So this, we've now been really, strong. My team and me and the patient, we've all been very together for 9 months or whatever. And now we're like, okay, we'll see you again in 6 months. And so that whole survivorship thing was something where I thought, it hasn't been a lot of talk about this. And so anyway, had the opportunity to nominate some of my patients to train for a women's sprint triathlon. And we all did it together. And they said, we need more of this. We need to work together while we're training. We're talking about things like, how do you manage your prosthesis? Or what about the hot flashes or whatever? This is a support group for people who don't want to just sit around the table for a support group. And so that was the formation of something that was referred to in my intro, Team Survivor Northwest. And Team Survivor Northwest, we founded in 1995. So it's amazing how many years it's been, and it is still going strong. And it's for all women diagnosed with cancer. And the only criteria, you don't need to be an athlete. Most of them aren't athletes. You just need to set a goal and work toward that goal. And it could be just to be able to walk around the block, for some of them, and others it's doing a triathlon. So I think that relationship with the patients and listening to them and hearing about, what their concerns were and being able to help in some way. I mean, and that's, that relationship led me to the weekend work. I fell into that Ukraine project. I was not interested in global health early on. I didn't think much about it. And then they offered, would you be the medical oncologist on this Ukraine project? And that was in the late 90s. I said, sure. And then I went, and then next thing you know, I'm, like, wow, we can really do a lot to partner and help and collaborate in all these other places. And so then I got that bug, and I got a joint appointment in global health and started mentoring master's students and all. So I love that global health piece that I added on that didn't happen until after I was all done with my training too.
Your passion for oncology is truly something amazing, Dr. Gralow, and we'd